The Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between. Well, hello again. Welcome to this week's episode of the Pediatric Lounge. With you, your host, Dr. Herb Bravo, and your host, Dr. George Rogo. Today, we have the pleasure of hosting Henry Dennis, who is the CEO of Medical Informatics Inc., a cloud-based software solution which provides data analytics to independent primary care practices to maximize the revenue realized through their participation in quality and value-based contract arrangements. Henry holds a bachelor's degree in computer engineering and a master's of science degree in administration. He previously worked for Mary Choice Health Systems, as well as big financial services firms such as Reuters and Citigroup. Please welcome him to the lounge. Morning, George. How are you?
How you doing, Herb? It's Tuesday once again for our podcast, and today we're going to elevate somebody that works in the medical field that's not a physician, but is a physician consultant that helps practices stay independent. And we're going to talk about quality metrics and dashboards, our favorite topic.
Great. Hi, Dennis. Welcome to the podcast. It's a pleasure to have you.
Thank you so much, and it's a pleasure to be here.
Thank you. Henry, you have a long, distinguished career in IT and healthcare IT. I'm a little jealous because I wanted to be a computer engineer, but my mother wouldn't let me. She said, you better be a doctor. So how did you get around to creating this new company that serves independent practices?
Thank you for the opportunity, Herb. Literally, I spent my entire career prior to getting into the medical field, healthcare, developing high-performance platform for trading application, electronic trading specifically. So that went really well up until about 2008. We all know what happened in 2008 with the crash on Wall Street. However, that same year, we had an election and Obama came in, and one of the first acts he signed was the High-Tech Act. Basically, that was the means of having the full power of the federal government behind the electronic medical record adoption everywhere. So we saw this as a great opportunity to take our deep expertise and move over to healthcare. Hence, we started this entire journey that brought us all the way to today with medical informatics as a platform to help independent practices navigate the world of value-based care and quality programs and all the pay-for-performance programs.
So when you were envisioning this new company, what problem were you trying to solve for physicians?
At first, it really was bringing this expertise into an industry that we felt could really use it. And we realized the industry really wasn't ready, okay? And then up until now, I'm not even so sure that we are at a level that we really can say comparable to Wall Street. It's not needed. So we came into the industry without that understanding. But by 2015, it started with the district program where in New York, providers were really being judged on outcome, pay for performance, pay for outcome. We looked out there looking for solutions for our clients. As consultants, that's what we do. And they needed something that would be easy to use and affordable, yet robust and feature rich. That didn't exist. So we ended up creating a very simple Excel-based application to help through the 5 years of district. And it worked just fine. However, the industry exploded and we started to see pay for performance becoming even more challenging and demanding for our customers. So by 2021, we ended up developing a full-fledged cloud-based platform. And then we created this company, Medical Informatics, MIFO Inc. for short, to brand it and go out there under that name.
And so what's the underpinning? What is the language, the programming language that you're using?
Sure. So our platform is AWS, so it's a cloud. You don't need to install anything, obviously. So it's all out there. So the latest programming language, our core language is Python, and we use different frameworks, and we use a SQL database on the back end, and on the front end, we're using a combination of React, PHP, and a smaller version of Tableau that AWS has that is called QuickSight. So that's really the underpinning. The way that it works really is that we take data from a lot of different sources, because that's what happens in medical practices. They have different contracts and they are all looking to have similar outcome, but using different routes. So data is coming from different sources. And the beauty is that we're able to merge all of those sources into a single place. And the provider practice, they have a single destination, and all of their data, all of their contracts is managed through that one single platform. And to our ability and capabilities, we bring some form of interoperability to that particular practice at a level that they can understand. And it translates into what we call a daily action list and guidance that tells the practice across all of their contracts, this is what you need to do today. This is what you need to concentrate on today. And if you are able to do those things and do them correctly, and obviously bill correctly as well, then you will be fine in terms of outcome.
You know what I've noticed is there's plenty of dashboards out there, plenty of companies all doing the same thing, Python, SQL, all words that doctors don't like. They like pretty pictures. And, Excel spreadsheets where an engineer can give you an Excel spreadsheet, doctor doesn't have time to look at that darn spreadsheet. Now, what I've noticed with some consultants is, yeah, they have the technology, the spreadsheets, the pretty pictures, but they also have the knowledge of the industry, which I think is more important than the technology in itself. I mean, by the time it filters down to a physician level information, that project's already over. So you tell the physicians, this is what you have to do for this year to be successful. And then they just do it. Is that correct?
I couldn't agree more. The idea of technology and medical practices, that's the love-hate situation that I call it. Okay. So the reality of it is that, yes, technology is needed, but you have to distill it down to the level that is accepted and acceptable to doctors, right? Doctors are basic. They went to school to practice medicine, not to become technologists. And that's what we try to do. We try to give them what we call a basic daily action list. This is what you need to do today, right? Doctors are trained to see patients and provide care. That's what we ask them to do. But we ask them to do this in a manner that is conducive to better outcome in their contract with value-based, companies.
Yeah, but the data is the most important thing. I mean, all physicians have the data, but getting it off of their computer onto something in a timely manner, that's a challenge.
Right.
It truly is. Interfaces would be the best way to work. However, they can be expensive, as you already know. A lot of times, your EMR will ask you for $5,000 to get a simple interface. Right. So the challenges are there. However, the balancing act is to still being able to provide a solution at a price point that is still affordable. And that's the challenge that we believe that we've solved in this marketplace, being able to provide a robust solution at a reasonable price. And the way we do it is really, really very simple. Whenever we can get an interface and someone wants to pay for it, you can have it. Otherwise, we just give you an upload button and we train you on how to do that. Because generally speaking, as Dr. Ubu said, you have the data, but being able to easily get it into a cloud-based platform so that anywhere and everyone can have access to it and produce better outcome, regardless of the number of sites you have per practice. That is really the key ingredient, right? If we call that the secret sauce.
What I've noticed with physicians is you ask them to do something, tell them to do something, they won't do it just because you told them, right? I learned that they're competitive creatures, physicians, from medical school 101. They're competitive creatures. They have to get it up. What I've noticed with your company, with Kalani, when she would send out the email saying, this week we had that practice A that uploaded successfully, B and C, D, and E didn't upload. That's where the competition comes in. So all the doctors want to be listed as doing a good job. So now we see that everybody is uploading appropriately. And then you get to make the pretty pictures with accurate data. So it's a competition piece. I think that's important.
So let me back up a little bit. I want to touch a little bit on the technical. So you don't have APIs with the big providers like OP or eClinical yet?
Correct. So you could be on any electronic health record you please. It really doesn't make any difference whatsoever. The key there is to be trained and have the ability to just pull the data that we need uploaded. So,
okay. You don't have an API with OP.
I do not.
Okay.
I do not.
And when you say you put a button, I have to run the report off of OP and then upload it to that button. How often do I have to do that?
Less than a minute.
But how often? Daily or once a week or once a month?
Once a week is the average, and once a week is really what we require. Otherwise, the information is stale.
Okay. And then you get files from the insurance company and you merge them in there. And what do you do with the electronic remittances and the outgoing charges that you put that into the database too?
That actually, we do it a bit differently. So the standard is exactly what you just described, or the data coming back from the insurance company. What we found is that if we do the same thing, then we will get the same outcome everybody else is having and the challenges that they are having, because they're relying on the insurance company's information, what we call the utilization data. Yes, we do take the utilization data into consideration. However, in most value-based contracts, if not all value-based contract, there is always the concept of you have to have certain thresholds met in terms of gap closures. And that's where we start. We look at your actual 837 files, which are the billing records outbound to the clearinghouse. And we are able to have access to all of the codes that are going out to the insurance company. So there are a whole lot of reasons why codes get dropped from the time that the coder puts them in the actual electronic file to the time that it's processed by the insurance company. And that may translate into gaps that are supposed to be closed and credit not being given. And as you already know, if you are supposed to be in the 80th percentile to have a passing mark at 79.9, you are not. So every single gap that is closed is quite important. So we look at what is going out, and then we look at what is coming back. And if there is not an agreement between those two pieces of data, we have an appeal process that is automatically triggered. And we do that on behalf of the practices on a monthly basis. So it is both ways, so as to make sure that the left hand and the right hand are in complete synchronicity.
Very good. So I get what you're doing. And how do you upload what each contract wants my practice to? How does that happen?
It happens at the onset. So there is always a setup process, an onboarding process. So that's when we get all the contracts from all the practices, and then we upload the contract terms, specifically in regards to what they call the scorecards, right? So the performance metrics. So this is how it's done at the onset. And that's what we utilize as we're processing data day in and day out to make sure that we are tracking the requirements of each contract.
And then you offer text messaging to prompt the patients that are behind to get what they're supposed to, either the vaccination or the colonoscopy or the physical.
Right. So that is the outreach piece. So that's a service that we can provide, and we can do outreach on behalf of the practices via text, email, or automated phone call. Right. The ultimate one is to have a human do it, but as you already know, that is the most expensive method. Yes, and especially when it comes to, the fourth quarter in yearly contracts. Now that we are coming into the fourth quarter, it's extremely important to have the outreach piece done right and aggressively, so as to make sure that we don't let our clients fall by 1 percentage point below what is considered the passing grade.
Do you data mine? Let's HPV. You're supposed to be at 75%, 2 doses before 13. And my practice is only at 50%. Do you text all those patients that are behind, or do you try to figure out who's most engaged to get that easy money first?
So it's a couple of things that we would do, and it depends on the practice as well. So if we have a contract that is considered what we call full service, right? So there are different levels. Then it would be completely our responsibility to data mine and make these decisions in conjunction with the practice and carry out the work. And if it is what we call a basic service, so the limitation would be that we would engage with the practice, but the practice would be the ones doing the actual outreach and doing the actual work, making sure that those patients come in. But at the end of the day, it really is a matter of conducting what needs to be conducted, but the data would be available either way.
Okay. And who owns the data? Who owns the data that I'm providing to you?
The practice always owns the data. So at any point in time, if for whatever the reason we part ways, obviously we will destroy the data, give them a certificate of destructions, that is required by HIPAA, and make sure that there is no sign of any of this data in our database.
Okay. You help people migrate from fee for service to pay for performance on the commercial space?
Correct. It is what I would call not necessarily a migration, but an integration, right? Because fee for service doesn't really go away 100%, at least not yet. Today, in the primary care world, it would be more like a 60-40. Fee for service is still approximately 60% in the primary care space. So what we do is trying to integrate fee for service and value-based in a single practice without having the big lift, right? The major challenge that a practice would face without the technology. We have seen fee for service, being mastered for the longest time out there, right? I mean, you have plenty of revenue cycle management companies, and that's what they do. That's what they've been doing. So they've mastered that world. The reality of it is that who is mastering the world of value-based care and pay for performance? And how are they integrating those two worlds together? That's what we do. We try to be that voice that speaks to the value-based world and connect it. So if you want to have a real picture, we look at that pie, and then we see it's got, frankly, two pieces to it, and then we connect the two. We connect the 40% and the 60% to make it a whole.
And you're doing that on the commercial contracts too?
Commercial contracts, Medicare contracts, Medicaid contracts, they're
Okay.
a bit different, but the concept, the ideas are the same.
The commercial payers are looking for cost of care and some quality metrics, or mostly the cost of care?
Both. So there's always the quality metrics aspect of it. However, the commercial payers are aggressively moving through the entire spectrum, right? So we have standard share savings, which is where Medicaid is for the most part today, right? So there's only upside, but the downside risk is here. And a lot of the commercial payers are very clear about that, and certainly full risk. So they cannot wait to push everyone to full risk. We pay you a capitation and you manage the patient. So, and if you make money, you make money. If you don't make money, well, too bad. We're not seeing a whole lot of this type of full risk yet in the government programs, but they certainly are coming.
Yeah, I think it's going to be hard for pediatrics to be full risk, but it's such a small amount of money and so difficult to manage. But
Well,
but
you know what
perhaps
happens? You know what happens? This game is not going away, the value-based contracts. So their wraparound, you could either participate and maybe earn some extra money by doing good quality medicine, or do nothing, or you'll end up joining some kind of a system, an IPA or a hospital system, or some big player that has all these things. But just like with everything, nobody cares about pediatrics. All right, so you get lumped in with the adult medicine, they go on the risk, they usually fail, and guess who else fails? The pediatrician fails too.
So
yes,
the idea of failure, right, and how this has been managed, let's take a look at Medicare, for example. How many iterations of some form of value-based quality care that we've seen in the world of Medicare? So in reality, a practice, an IPA, a CIN enters into a value contract and they fail, what are the consequences for that IPA, for that CIN? Let's just be clear and open about that, right? So my view of the world is that, yes, we are pushing for full risk. However, how easy is it going to be to actually enforce this contract? Is that CIN going to go away? Is that IPA going to go away because all of a sudden they have a $2 million, loss? Is the insurance company going to say, okay, so your 3,000 doctors, they cannot participate anymore and you're gone? What happens to service? What happens to availability of service in certain area? And it all boils down to access. So that's a conversation that really needs to be here. That's a conversation that really hasn't been happening as much as I would like to see it happen, frankly. And even at the large conferences, is the same conversation that is not happening. Reality of it is, yes, you're going to get insurance. And if you have that failure and you have a $2 million risk, then you hope that your insurance company is going to write a check for $2 million. Fantastic. What is going to happen to your premiums? So the reality is that we're seeing those risks that used to be at the business level being pushed down to the provider level. The groups that are being formed able to really deal with that level of risk. That's the question to be asked. And I'm not sure that anyone knows the answer.
Well,
but at the end of the day, I don't think access is going to ever be taken away. It cannot, because the patients have to be seen.
Well, we had experience with that in the early 90s, and the experience in California mostly, some in Virginia, where groups of adult and pediatric physicians would contract full risk. And just like you said, some kid would get leukemia and need a bone marrow transplant and $2 million of care. And the medical group did not have the resources to pay for that $2 million. And they would just go bankrupt, close shop, and start all over again. So we've tried that, and that's supposedly why insurance companies exist, to take on those catastrophic risks. So I don't see, at least in pediatrics and, outpatient pediatrics, full risk ever being an option. Physicians don't have the deep pockets to take that kind of risk. Maybe so, somebody like Optum with 60,000 physicians, maybe they can take that risk on the Medicare side where they can save a lot of money. But on the commercial side, that's going to be tough, especially for the very young people.
Yeah.
How many physicians, or I don't know how you count them, physician practices are part of your network now?
We count them by NPI. So the license is, managed via NPI. We have a bit north of 200 NPI, active NPIs on our platform today. So we started in 21. So that's been the growth, managed. And the reason is very simple. We work collaboratively with the providers quite a bit. It's not a matter of technology, really. It's a matter of the medical practices that are using this, and we listen to them and we listen to what they have to say, and we manage out their expectations by updating that it becomes user-friendly. We will scale significantly in the near future, because at the end of the day, the people that really need our platform are the people that cannot buy it, right? They cannot build it, and the only answer for them will be to partner. And they are out there already. We call them the revenue cycle management companies. They are the ones that are seeing their revenue decreasing significantly as for services being compressed, and they have to do a whole lot more to maintain their revenue level, their income level. So when you think about it, they bolt on our platform to theirs. Now they participate in 100% of the revenue, and their clients are happy and they are happy. So that's how we plan on significantly scale in the near future.
We're not talking, I'm a single provider and I'm going to join, I'm going to hire a platform. I'm not having to put out $25,000, $50,000 to join.
Oh, no. The answer is you can. As a single provider, you can join in. We have plenty of single provider practices that are on our platform. We have groups as well. So we built this for the simple reason that our customers could not find a platform that was affordable, robust, feature rich. And that's our philosophy. So it will remain that way. So with $50 per doctor per month, anyone can join in, right? In the markets that we serve, obviously. We're not national, we are regional. We want to make it affordable, and we certainly encourage anyone to try it out for free. We encourage anyone who wants access to really try this out. It's built for that very purpose, and for those people that cannot buy, that cannot.
When you say you're regional, are you just in New York right now, or are you?
Right, we are in New York right now.
Okay.
Right. So
And-
we serve New York State as a whole. Right. We do not have the contracts from the neighboring states or any other states. We will expand, but right now we do New York plans only.
And what's the pain point there? Is just getting clients in another state, or working with insurance companies? What prevents you from having this data?
Every state has their own rules and their own contracts, and implementing all of them on the platform at the same time would be extremely expensive and not necessarily beneficial from a return on investment standpoint. So it will be a gradual and controlled expansion so that we are able to provide real value. Let me be specific. So if you look at the geomap that we've built for our region, you'll notice that it covers certain regions really extensively. We have a lot of providers that are participating in the state programs. So really what happens is that a particular patient may be with insurance A today, and then they lose their eligibility tomorrow with the insurance B. And then their parents are starting to work. Now they have commercial insurance C. But they may still be Dr. Rogu's patient. Now, what Dr. Rogu is going to be dealing with is that today he's going to be looking at that patient through the lenses of this particular contract with insurance A, tomorrow with insurance B, and then tomorrow with insurance C. And they're all going to come to him asking for the exact same thing. Our view is, once you are a client, you don't need to worry about these things. The patient can move from one place to another with a single signature on the part of the patient. We are able to move the services, the credit, the gaps that have been closed from one place to the other. So when we remain regional, then we lift the burden off of our providers, because insurance companies cannot know, because they don't have the utilization data and it doesn't transfer from one insurance place to the other. So in being regional, it gives us this advantage. So when we are expanding nationally, we want to be able to offer the same type of services and opportunities to everyone else.
Great. And then what are you seeing on the Medicaid side in New York? So Medicaid has wraparound contracts in New York, right? That's what they're doing.
Right. So in wraparound in regards to the Medicaid, Medicare, we are talking
just Medicaid, just value-based Medicaid contracts. Because as pediatricians, we don't really do any Medicare.
Right. So what we are seeing generally is shared savings. So I know of one group that has a full risk contract. I don't know of two, only one that I know. I'm not sure how long that is going to last. We do know that the pandemic did slow down the entire plan for New York State to push providers into risk contract. So the plan was by 2020, it should have been level 1, and then level 2 and level 3. So right now we're still at level 1, which is upside only, shared risk. So how fast is that going to move? We don't know. I know that we're starting to see conversations along the lines. Okay, so now it's time to push the envelope forward a little bit. But I think there's going to be a whole lot of resistance on the part of the provider community to go down that.
Yeah, that's going to be difficult, isn't it? What haven't I asked you that you think is important for physicians to understand about data migration, data mining, all those things that you probably they're so easy for you in Wall Street, but are new concepts in medicine?
Totally new concepts in medicine. What physicians have to understand is data is their friend, not their enemy. Data is really the new currency to be embraced rather than shy away from. I get it. It's not normal. It's not natural. It's not what they went to school for. It's not what they go to bed thinking about. However, you don't need to be a geek to really take advantage of data. You really need to be thinking of data as a tool to be used, but I just have to give myself a little bit of openness and training. That's really what it boils down to, being a bit open, right? I feel at times that a number of physicians are thinking, I'm too old for this. It's not what I want to do. It's not what I want to school for. But what are the choices? Are you going to retire tomorrow? Probably not. So embrace it. If you cannot fight it, if you cannot avoid it, embrace it. You don't need to become a gig. If we do not do that, what will happen? Well, we see the consolidation going on out there, and we see independent practices really being, squeezed. So at the end of the day, we need the physicians to be in the community, to be servicing the community. We know that primary care in the community setting is the most effective and the least expensive. So that tells us data is your friend, and data is the key to remaining independent so that you can continue to do what you really want to do. Otherwise, if you outsource this entire data thing to everyone else, you are going to be an employed physician, right? Because you are going to be seeing the patients and let everyone else take care of everything else for you. That is an employed physician. But if you want to remain independent, whether you are independent on your own, which I do not recommend, or independent as part of a group, then someone is going to take the responsibility of being a leader and putting in place an infrastructure that will take care of you and that will help you with your value contracts. So it's a matter of a bit of openness and really understanding that data is the friend, and accept a bit of training to see and utilize it in a manner that is conducive to better outcome for your practice.
Right.
So I find that
get out of their silos. I think they have to learn to work together, yet stay independent, or work together to continue to stay independent is a better choice of words.
Right. It may sound like an oxymoron, right?
Mhm.
However, that is the real way of doing it today. We are competitors and we are collaborators.
Correct.
We are competitors in the sense that we're all after, quote unquote, the same patients. But we are collaborators because at the end of the day, when we get together, we become strong. We have the power. It's not just a saying. Power is in the numbers, right? Power is in the numbers because when we pull a couple hundred pediatricians in a general area and we pull them together, now all of a sudden you have real power because you control a group of patients and they depend on you. So and everybody else who is the payer, they're going to have to sit at the table and discuss this with you. And that's the power that is in the numbers. And that's the power that would allow you to negotiate better contracts. And that's the power that will allow you to carve out those things that are going to be causing, ACIN and IPA or any group that is entering into these contracts to not go bankrupt.
Yeah. You know what? It's not better contracts that they're looking for, really. It's a contract in itself, a value-based contract. So if you're an independent physician practice, you have 200, 300 patients per one particular insurance carrier, they're not going to talk to you because they know you don't have the infrastructure or the capability. They're not going to basically waste their time to give you a contract because you don't have enough of a patient base. But if you become as a group for value-based contracts, like through a CIN, you take 200 from one practice, 100 from another practice, 500 from the third, 1,000 from the fourth, and you pool them all together. Now, all of a sudden, you have 5,000 patients. Now you're a force. I remember doing a negotiation with one managed care Medicaid plan, and they humored us because we had a large patient base collectively. And they said, you know what? Pediatrics is a very, very small percentage of the expenditure in our practice. But you know what? You guys seem to be organized. So we're going to humor you and extend a value-based contract. We proved to them through the geomaps of how many patients we have and the quality metrics. And fast forward, we did have shared savings with them because pediatricians do it right.
I always find it interesting when physicians push against data because all of our training is about data, right? You don't give a kid azithromycin for otitis media because the data shows that amoxicillin works better for the bug than azithromycin. But then when it comes to dealing with data in our practices, everybody just gets panicked. And it's, I mean, everything we do in the exam room is based on studies that look at data. And if we do one intervention, what's the outcome? Data is just the same thing. It's just at a population-based level, not at an individual patient level.
Correct.
Well, I look forward to the expansion of your company because I think there's a lot of independent practices across the country that would benefit from it.
Yeah.
Like independent practices. And so I think this is a very elegant and cost-efficient way of starting to move the process in that direction. We just got to get you more and more clients.
Yeah.
Because
They're getting a lot of clients.
Data, the more data points you have, the more information you can mine.
Right.
So
Totally.
Okay.
Yeah.
Thank you.
Thank you so much.
Thank you for the opportunity. I really appreciate you inviting me. I enjoyed the conversation very much, and looking forward to an encore, and best of luck in the podcasting world as well. You guys have been doing a fantastic job.
Thank you. Thank you. Thanks for coming on.
Most certainly.